So it's a pleasure to present the next presenter. We're a truly interdisciplinary session, so it's rarely to have a cardiologist here. Dr. Bampali from Greece is going to talk about the trajectory of coagulation management, perioperatively, current practice, and future perspectives.
Thank you very much. Good evening, dear colleagues. It's a great honor and privilege to be in this session. To start with, there is this continuum axiom that cardiac surgeons are afraid of bleeding and cardiologists are afraid of thrombosis. To be honest, being an ICU doctor, I have to say that I'm afraid of both. It's a very tricky balance, and I have to admit that perfusionists and anesthesiologists are fearless. The typical surgical candidate has this labyrinthous cascade of clotting process. He takes antithrombotic drugs and he has at least 2 significant comorbidities. So the balancing between bleeding and thrombosis is really difficult. We do know that MiECC technology has the ability to decrease hemodilution, transfusion, serious inflammation, and platelet segregation, which means that we have a less risk for heart failure deterioration, risk for trial less risk for pericarditis, less risk for post-operative atrial fibrillation, up to 30%, like Dr. El-Essawi told us before, and less risk for thrombogenicity, which means that we have better organ and tissue perfusion and preservation of the renal function. There are some non-modifiable risks regarding the target to decrease RBS transfusion, which is the gender and the age. And of course, we have on the contrary the paradox, the obesity paradox. But the rest are in our hands in order to reduce RBC transfusion. At the preoperative period of time, we have to be a proper prepper. You have to know the patient, especially the kidney function. You have to correct anemia, and you may use intravenous ferric oxymantal, and of course, correct renal function by withdrawing nephrotoxic drugs. You have to know the comorbidities that affect thrombotic and bleeding risk, like kidney function, diabetes mellitus, heart failure, atrial fibrillation, rheumatology disease, or cancer. You may use scores to delineate these risks, like ARC-HBR criteria or even the frailty score. You have to know the drugs because we have now novel drugs like cangrelor and they have elimination time. You have to know the drug-drug interaction because some drugs like non-CCBs that are currently used by the cardiac surgeons may increase the Beckett's effect. You have to be very careful with the breathing and define the time of antithrombotic drugs discontinuation. You have 3 options. You may wait, you may use platelet function testing, or use antidotes. In that case, you have to know the antidotes that you have in your department if the surgery is urgent or emergent. For example, the rituximab is applicable to in almost every hospital, especially in my country. You have to stop on time. Regarding antiplatelets, you may maintain low dose of ASA during the perioperative period if the surgery is non-emergent. If it's a non-coronary cardiac surgery, or the patient refuses to transfuse, or it's a high bleeding risk, you may stop aspirin up to 5 days prior to surgery. Regarding P2Y12 inhibitors in non-emergent cardiac surgery, you have to postpone the surgery for at least 3 days for ticagrelor, 5 days for clopidogrel, and 7 days for prasugrel. You may use platelet function testing if you want to guide decision with a less level of evidence. Regarding the coagulants, antagonists of vitamin K must stop 5 days before the elective cardiac surgery and targeting INR less than 1.5. Regarding DOACs, you have to stop them up to 48 to 96 hours prior to the surgery based on GFR and the regimen. You can see here in this nice demonstration by the post-trial by Dr. Ducatis from the States. Regarding breeds, you must not breed P2Y12 inhibitors or aspirin with low molecular weight heparin or fondaparinux. It's a totally different drug. You do not offer nothing to the patient. You just increase the bleeding risk. So you stop the drug and wait. Also, you do not breed antagonists of vitamin K unless there is a very high thrombotic risk, for example, a mechanical valve or severe mitral stenosis. You have to stop the VKA, wait, and proceed if the INR is less than 1.5. You do not breathe also when you stop DOACs unless there is a very high thrombotic risk. If you must, in some cases, breathing with 2B3A or intravenous cangrelor, then the only option is if the patient is of a very high ischemic risk. within 1 month of a STEMI or PCI, or if there is a history of stent thrombosis. You may stop cangrelor 1 to 6 hours before the cardiac surgery, and the 2B3As 4 hours before the cardiac surgery. If you decide to bridge, use preferably unfractionated heparin. It's not easy to use, but you have a way to monitor it. Only if the INR is less than 2, and of course avoid fondaparinux. In this case, stop classical heparin 6 hours before the cardiac surgery, or the low molecular weight heparin 24 hours before the cardiac surgery. Intraoperatively, the management is very tricky, it's beyond my field. It's already been told very extensively by this summit. MiECC technology by itself, it's a very high asset in all spectrum of cardiac surgeries that preserves blood loss. We have a lot of point-of-care testing that facilitates individualized heparin or protamine management in order to prevent, rather to correct, perioperative bleeding. At this point, I want to highlight the enormous scientific work by this Center of Thessaloniki by Professor Anastasiadis, Antonis, and Argyriadou. Of course, there are new rising protocols targeting less threshold for ACT, for example, 300 seconds, and some new technology. But in the post-operative management, where we can do a lot of things, you should start aspirin within 24 hours after the surgery if there is no bleeding concern. Also, you may start P2Y12 inhibitor post-operatively within 48 or 96 hours regarding the initial cause of the surgery. You may resume cangrelor, which is an intravenous drug, within 12 hours after the surgery, and restart ultrafractional heparin 12 to 24 hours post-surgery, low molecular weight heparin 24 to 48 hours post-surgery, and DOACs, you have to wait until 72 hours post-surgery, and then you have to stop the heparin. By guiding this nice table from Professor Duketis. Regarding VK antagonists, you have to wait 24 hours post-surgery, then bridge with heparin, and stop then when the TTR INR is on target for 3 days. Some tips beyond the proper drug management. Remember drug-drug interaction. For example, paracetamol may increase VK effect. If you have to combine therapies, the less the merrier, which means that you have to do this for a shorter duration, use lower dosage, de-escalate if possible, and of course, redefine the original indication. Correct anemia with intravenous pericarboxymaltone, which gives you the ability to postpone RBC transfusion and wait. Remember heat, it's quite common, especially type 1. In that case, you have to change low molecular weight heparin with fondaparinux for thromboprophylaxis. Remember that there are several antibiotics that induce thrombocytopenia, like glycopeptides, that are very usually used in the post-operative era. Check often GFR and adjust the dose of drugs, avoid non-steroids, and assume high dose of statin as a stabilizer. As for future perspectives, we in the future may have one antidote that will coagulate blockage, also for heparin and DOACs. Currently, there is in phase 3 the drug siraparatan, and we wait the result of those trials. We may see new devices and graphs like the Onyx technology. Genotyping is also a possible perspective in order to find the optimal drug choice and combination and personalize the coagulation management. We may broaden point-of-care testing, even in the outpatient area, in order to address the platelet aggregation of the patient and guide better the antithrombotic therapy. Artificial intelligence is a new rising way to engrave the optimal drug choice and by using predictive analytics and standardized protocols. And of course, MiECC technology by itself, by broadening its utility, it's a very nice way to facilitate coagulation intraoperatively. And maybe in the future, we may see even more advances. Until then, you have to follow the guidelines and believe that the less is the merrier. Thank you very, very much.
Thank you very much. Are there any questions from the audience or the panel?
Thank you very much. This was very useful. I would like to ask Professor Baufreton a question, really, if I may. we know how vague the ACT measurement is in terms of controlling what's really happening, but it's a very useful tool because we have it there in the operating room. Do you think, as most of the data are old on the safety margin, now with all the newer methods of assessing multiple stages of the coagulation, especially on the intrinsic pathway, do you think that, and Professor Anastasiadis may respond to that too, there is space for new trials, especially on the MiECC system, to actually check? Because my clinical experience, maybe because I'm just too impatient nowadays, is most of the time, as you mentioned, when I reach 350, I have a little quarrel with my perfusionist saying, go on. And he keeps saying, as you say, no, you. I said, my responsibility, go on bypass. And this is very anecdotal, but in a few thousand cases, we never really faced the problem, while we have this vague idea that when we are high, towards the end of the operation, we're struggling to get things back together appropriately. Of course, most of the time in conventional systems. So do you think there is lack of evidence with current literature? That's the question.
Yes, thank you for a question. Yes, of course, I think that we could improve the knowledge by having more new studies in that. To my knowledge, I think that except the study of Adrian Bauer, comparing low ACT 300 seconds to regular ACT, I mean regular between brackets, of course, and he demonstrated the benefit of that approach. We have to think and to remember that the guidelines we are using are probably built on moving sands. I mean, there is no huge evidence, strong evidence, to justify such elevated ACTs. So we are, when using a MiECC, giving to the patient all the best that we can do. I mean, closed circuit control of pericardial shed blood that is eliminated, which is very important, you see, very, very important to avoid clotting. I mean, sometimes it happens in my practice that I see some clots in the pericardial cavity. I'm not afraid of that because I know that what is a coagulation is a pericardial cavity has nothing to do with what is present inside the circuitry or inside the bloodstream of the patient. So we have to increase our knowledge about that. And once you have a good knowledge of this pathophysiology, and which is probably the case of every attendees of this meeting, but maybe not all the surgical community, then it is possible to go furthermore. And in the situation where we are facing many, many patients with double antiplatelet therapy, it's very important to avoid such an explosion of the transfusion rate.
Thank you very much. Thank you. We have commentators. Dr. Saridou is here and would like to make a comment. No? She's on duty, maybe. Dr. Jenni or Dr. Jansa would like to add a comment.
I have also a question about the low ACT. I know that Adrian Bauer, he used a type 1 or a type 2 completely closed. And we know even for ECMO, it's quite an ECMO. And with the experience from ECMO, sometimes we also went on ECMO without heparin sometimes, and it worked because it is completely closed. But do you think if we go with a type 4, for example, would you also, do you have some data or a recommendation from your side in which region we have to go with the ACT?
May I comment on that? Yeah, first of all, Christoph said there is Bauer's paper. Last year, we published a paper with 132 patients from MiECC with low ACT. So have in mind, Hans-Georg, that type 4 is type 3. It is always closed. It is like all the rest of the closed systems. That's why we go as low as 300 for cabbage cases and 400 for all the rest of the cases. It's type 3. So when we say type 4 opens only if you have to do it. For example, an exapectic scenario, when you do a cardiac, an arrest for circulatory arrest for doing arch surgery, only that. So with this low ACT protocol, go and review our paper. We had no problem. And actually, our bleeding problems postoperatively are much less, and the protamine use, which is the most significant thing for us, was very, very low. So if we say type 4, we normally say type 3 circuits with low ACT, as I don't know who pointed out, I think it was Christoph, avoiding shed blood and have no blood-air interaction is completely safe. And we can prove that with our studies.
Thank you very much. Professor, would you like to? Yes.
Yes, in my practice in our hospital, since 20 years, we use for cabbages type 3-like system for cabbages. There is only a social reservoir, and that's all. And we reduce the target ACT to start the CPB at 250 seconds. We are submitting currently an article with more than 3,000 patients operating on with this program. And I can tell you that this is very safe. There is no problem. For the valve operation, it's a little bit different. We consider the impact of the blood-air interface in the reservoir, the arterial reservoir. This is the reason why we increase the ACT at 350 seconds. But we do all the surgery like this. I mean, aortic valve surgery, mitral valve surgery, everything like this, except the cabbages with a lower ACT. So the only issue I would like to think about and to emphasize is if you do valve surgery and you use CO2, which is a highly thrombogenetic gas, then maybe you have to be very careful for that. This is the reason why I never use CO2 to the other heart, because in addition, it will open the vessel of the brain and promote some strokes. So I'll be very careful with that. But for regular patient, because we are talking for most of the regular patient, I mean, this protocol is safe. And once you understood all the major parameter of blood coagulation and hemorrhage, then you are successful. It's really a question of philosophy, physiopathology, more than a question of device that is provided by the industry. You have to adapt yourself.
Thank you.
To make myself clear to Hans-Jörg, when we have to open the system, in that situation, Apostolos always gives heparin, always. So gives heparin, open the system, we go up to 500, and then we open the system immediately. Otherwise, when you go to type 4, you need to give heparin. We have not tested low ACT 300. When you open the system, as Christoph pointed out, we always give heparin, give heparin, and then he opens, always, immediately. Otherwise, it's dangerous. So you then open, suck from the shed blood, then might create a disaster. So
that was the question.
Yeah. But we operate on type 3. As Ashraf said, we created a chaos to the literature. Type 4 is a readily available hybrid system. But when we normally operate, it's type 3. We don't open.
The question was exactly that. If you open that.
Oh, absolutely. No. Always, Before opening, he gives heparin, he's here. Gives heparin,
Okay.
then.
Thank you very much, Professor. Any more comments from the panel? This was a very interesting session. I think we need to conclude here because there's another interesting session coming up with the interesting. Thank you very much.
Thank you. Have a great good trip back.